Some of the presentation goals, some of the things that I want to cover over the next 20 minutes are to identify some of the various manifestations of OCD, so the different types of OCD. OCD can present in a variety of different ways, some of which we're familiar with and some that we're not. I want to talk a little bit about some of the core cognitive distortions in OCD, so the styles of thinking that we have. I'm going to spend the bulk of my time, because I think this will be of greatest interest, family accommodation versus family support. And then lastly and briefly talk a little bit about PANS and PANDAS. So in terms of the OCD manifestations, I put two slides in here. One is on the obsessions or the thoughts, and the second will be on the compulsions. Okay. So in terms of the different obsessions or thoughts that you might see with OCD, the first is one that people are quite familiar with, and that those are the thoughts around contamination, things like germs, AIDS, bodily fluids, illness, stickiness we'll see. There's lots of different manifestations if you look in the literature. Some of the folks when I'm training them, I tell them not to get so caught up in a specific label because there can be some overlap with things. But I try to give you just a general overview of a different variety of ways that it can manifest. We can have stuck thoughts about aggression or violence. So we can have children that have concerns that they might hurt themselves or someone else. They might come in with a suicidal obsession. And any of the things that you see on these slides are things that can occur for anyone of any age. Oftentimes what we say is what you resist persists. So really whatever is important to that person and is something that they wouldn't want could be the content of the sticky thought that they have. There can be overlap in manifestations. So I might have a child that I work with who is worried about harming themselves. They have a suicidal obsession. Fears of hurting oneself with a knife can be a really common manifestation of a pediatric aggressive obsession. Worries about hurting somebody else, harm coming to them through the child's hands or through some other means, blurting out obscenities, racial slurs, stealing, any sense of stuck thought about being responsible for terrible things. So kids can have, again, some overlap in that they might even have some jinxy thoughts that if they don't have a good thought and replace a bad thought with the good thought, that something bad might happen to someone else. So there's a sense of hyper-responsibility there that for the child they may recognize is really not logical or doesn't make sense, but nonetheless OCD tells them that that's possible. We can have children who have sexual obsessions that seem forbidden or perverse, sexual thoughts. A really common one that you'll see with adolescents is a what if I'm gay thought. The adolescent could identify as being gay or being homosexual and worry, what if I'm straight? And have a stuck thought about that. So again, we say what we resist persists. So whatever it is for that person that doesn't feel comfortable to them, doesn't feel okay to them, could be a stuck thought that they have. It can manifest as hoarding or saving, a fear of losing things. So these might be kids where their room is really cluttered, or they keep a lot of their papers, or they keep certain possessions. They may have some excessive emotional attachment to items. They may even get some magical thinking about if I throw something out that belonged to my grandmother, that that's the same as me throwing out my grandmother, or it signals that I don't love my grandmother. And again, for the child, depends a little bit on the level of insight and maturity. They might be able to say, I know that's not logical and it doesn't make sense. However, it just feels better when I keep it. And that's not to say that, I want to be clear that any child that has a messy room or keeps things, it may or may not be as a result of anxiety or OCD. There can be lots of reasons for that, but OCD might be one of the reasons. Kids can have magical thoughts or superstitious beliefs, unlucky numbers, colors or words. Oftentimes odd numbers tend to be unlucky numbers, but not always. What you'll find with OCD is the stuck thoughts are very unique to that person. And it's really important to ask really specific questions in terms of the harm that they're concerned will come. They can have somatic concerns, so intrusive thoughts about concern with illness or body parts or appearance. They can have something called body dysmorphic disorder, where they get really stuck thoughts about a particular part of their body and feeling like it doesn't fit or something's out of place. They can have religious obsessions, concerns with offending God or concerns with right or wrong. There can be hypermorality. And lastly, what falls under a miscellaneous category, needing to know or a fear of saying certain things or intrusive sounds. And again, there can be lots of overlap in these different manifestations. And we can look at lists that are, even longer than this, but this just kind of gives you a nice quick summary. In terms of what we would see in response to that are what we call compulsions. Now, compulsions can be overt or covert. So what that means is that we may be able to see the compulsion or we might not be able to see the compulsion. A lot of OCD and its compulsions might not be able to be seen. They might be a lot of mental analysis. They might be body scans. They might be undoing a bad thought with a good thought. So everybody's pretty familiar with washing and cleaning, like hand washing and showering. I can tell you, a number of times if I'm having a consultation with a school and, I'm letting the teacher know that, some of how the OCD presents, I might have a teacher who says to me, it doesn't seem to me that this child has OCD. They don't wash their hands. And so there's a lot of misunderstanding about what OCD is. And while washing or cleaning might be one of the ways that it manifests, it certainly isn't the only way. So we can have checking locks, checking toys. They can be scanning their body to see, did I have a good thought or a bad thought? Does it seem like I might want to hurt somebody? So they could scan their body. If somebody has a sexually intrusive thought, they might scan their body to see, do I seem like I'm aroused by this person or am I attracted to this person? One of the difficulties, with a behavior like that is if you're an adolescent and you're scanning your body for signs of hyperarousal, guess what's going to happen, right? And so then that's really scary for the adolescent because then to them, it seems as if it's true that whatever their stuck thought is about might be that much more likely. They can have repeating, rereading, erasing, repeating activities and questions. So this is where you'll see kids with a lot of reassurance seeking. They're asking the same question over and over again. Ordering, arranging, evening things, symmetry, touching, tapping. I might have a child who, touches their fingernails to kind of get it just right because there's a sense that their fingernails might fall out. Now, for that child, they might realize that that is not going to happen and it's not true, but nonetheless, they feel better when they touch it. It just gives them a sense of certainty or just right. Hoarding and saving, keeping things, excessive games or superstitious beliefs, so maybe touching objects a certain number of times, repeating things, walking through the threshold of a door over and over again to get a just right sensation, blinking or breathing, trying to get a just right breath, and all kinds of miscellaneous compulsions, including mental rituals, thinking about things, telling, asking, confessing, touching, tapping, all kinds of stuff. So there are many compulsions that you might not be able to see. So I'm going to go through some of these cognitive distortions. I tried to, like I think all the presenters probably put a lot of information in here for you, probably more than what we can do during the time. But I wanted to just briefly go through some of the core cognitive distortions. So one of the main cognitive distortions in OCD is an intolerance of uncertainty. And it's really the tie that binds all OCD. You can see an intolerance of uncertainty in social anxiety. You can see it in GAD. You can see it in separation anxiety. You can see it woven throughout all forms of anxiety. But in particular with OCD, it is one of the main cognitive distortions. And as an OCD specialist, when I hear somebody talking about a need to know or a need for certainty or they just couldn't sit with the doubt, as soon as I hear that, my OCD antenna kind of goes up. So for that person, they believe that they need to know for sure that the bad thing won't happen. So one of the kids that I was just seeing right before I came here today, some of his worries have kind of manifested almost in a little bit of like anger and pushing, testing some limits. And so he just started getting into Rubik's Cubes, and his parents bought like a lubricant to go in the Rubik's Cube so that it would go more smoothly. And apparently the lubricant came before he was supposed to use it, so he was supposed to wait until his dad was there to use it. And his brother went ahead and used it without permission, and he did tattletale on his brother, which was a little bit of a just right thing. He wanted his mom to know, that what his brother had done. And one of the things he was really stuck on was this idea of what would the consequences be. So he wanted certainty about what the consequences were. So he wanted to know, he's kind of bartering with himself, should he use the lubricant to get his Rubik's Cube to move more quickly or not? What exactly was the consequence going to be? And what you would hear him saying is asking repeated questions of his mom, like, what will the consequence be? So you feel that need for certainty there. And this is woven throughout OCD, that there's just an overimportance given to our thoughts in general. And as human beings in the culture that we live in, just in general, there's overimportance that we give to our thoughts in general. There's a lot of stuff that goes on in our head that we listen to and we take it as if it's fact. And in particular with OCD, that's the case. We can have something called moral thought-action fusion, where we believe that an unwanted thought is morally equivalent to performing a terrible action. So if we have kids who have a sexual obsession, that they're worried that they may have aggressed upon a peer, if they are worried, and you'll see this a little bit more with adolescents and young adults, but they worry, what if I sexually abused a child? Or I have a young adult who I've kind of known for many years, who's worried that he had a sexual encounter with somebody in college, and he's worried, what if I raped them? With the Me Too movement, you'll see that content that's happening in our society can definitely play a role in terms of the stuck thoughts for clients. So the idea that I had a sexual thought can feel as if it's morally equivalent to performing the act. Need to control thoughts, so a belief about the significance of the thoughts lead us to feel that we need to control them and we need to control our actions. And you can imagine the more that you try to control your thoughts and you try to control your feelings and you feel this like impending need to control your actions, sometimes the slipperier that feels, and then the more anxious the person may feel. Another cognitive distortion is the intolerance of anxiety, that we feel that anxiety or discomfort will persist forever, and that the tendency is to want to escape and avoid that because it feels so uncomfortable. And you'll see that cognitive distortion woven throughout all anxiety conditions. A just right error, so feeling that something has to be just right or perfect in order for it to be comfortable. You can see this with kids, maybe with the letters that they make, so wanting to close the O just right, not wanting to move on with what they're reading until they feel like they have a just right sensation with the reading, that they perfectly understood what they're reading. And you can imagine for kids that can make it really difficult for them in school, and particularly as the workload increases and the reading increases and the writing expectations increase, that the need to have things just right becomes more and more of an impediment of them moving on. Emotional reasoning, that we assume the danger is present simply based on the fact that we're feeling anxious. So we reason from how we feel. Okay. So now I want to talk a little bit about family support versus family accommodation. And I think this is a really tricky issue. It's really hard, to get it right. I think in particular, part of the reason that it's hard to get it right is that it just feels really intuitive to help your child when they're feeling anxious. It feels really intuitive to answer their questions. And so we're biologically wired, and I like to think sometimes moms are even more biologically wired, no offense to the dads, but if I can say so, sometimes we stink at not giving our kids, the reassurance. We just, it just happens so quickly. We want to comfort them and reassure them. I can say that for myself as a mom. And so unfortunately what happens is we're inadvertently reinforcing the anxiety when we do that, that we are actually giving it more functionality. So our parent tendency is to reassure and to comfort and to overprotect, and it's really intuitive. We may feel like we're walking on eggshells. We don't want to upset the child. We may hesitate to encourage the child to take risks, which is exactly what we want to do. We want to encourage kids to take small risks. We may allow for escape and avoidance. We may push hard with our kids and maybe even punish them, and then we feel really bad and we make it up and we say sorry and we take it back. We may feel worried and sad and frustrated and angry and guilty. So I just really want to normalize and validate it, that accommodation is really normal and it's common and it happens, right? And so it sometimes feels like we're avoiding the normal trap when we have to parent the anxious child, because we have to do things very differently. And we have to kind of go against sometimes our instinct as a parent to rescue and reassure, and instead to encourage them to take risks. So I think Marty will probably talk a little bit more about this OCD cycle. And this is just a really good basic understanding of OCD and the cycle in which it occurs. And so we have these obsessions or unwanted distressing thoughts that make us feel anxious. And what we do to feel better about that is we engage in compulsions. We engage in some kind of behavior. So what we're looking to do, instead of accommodating, is we are looking to remove those accommodations gradually, kind of do it once and done, give the compulsion a limit, delay doing the compulsion. We can give rewards for moving out of the comfort zone or doing what we call ERP. We can have something called scheduled worry time. So that's a time when we can discuss the worries, but it's on our terms. It's not contingent with when the child feels anxious. We might engage in active ignoring. So while we're also attending to a preferred behavior, so we want to reinforce the behaviors that are helpful to the child, but we might choose to use something called selective ignoring, so that we're not reinforcing and aiding the anxiety. And we might use some strategic pressure sometimes with clients. So what we're doing is, if the child is not willing to take the risks, we might engage in behaviors that really push them in the direction of taking risks. So in terms of handling intrusive thoughts, we might accept the thoughts as normal. We're not trying to fix them. We're going to try to let ourselves have the thoughts. You know, I'm having the thought that, and I'm going to choose to live with them. I'm going to face the thoughts and the things I would like to avoid, and also celebrate the successes. So this is a slide from Irene Pinto Wagner. And this is just a classic example of what we call riding up and down the worry hill. So what we're encouraging kids to do is to kind of metaphorically, you know, ride their bike up the worry hill, hit that panic point and continue to come down, as opposed to doing what they would like to do, what we'd all like to do when we're anxious, and that is to engage in some kind of compulsion. When we engage in the compulsion, what happens is that it gives us immediate relief, but the difficulty with that is it just reinforces that behavior. The other difficulty with it is when we do that, it actually makes our world smaller. So if we were able to do something that was an 8, 9, or 10, but we accommodate it and we avoid that risk, we avoid that thing that makes us feel anxious, then the next time, because OCD is a big bully, what it does is it says, okay, something that's a 6 or a 7, now you can't do that. And then if we comply with OCD, then it takes even more room. And it says, now you can't do things that are 3 or 4. So the way I'll draw it for kids is that the line may start here, but eventually it moves here to the point where we keep feeling like we're really stuck in this cycle with OCD. So these are things that I have parents say in response to reassurance seeking, because this is really a big part of what kids who have anxiety will do. I have all kinds of answers for that. One answer is good enough. You're probably going to get this wrong. What do you think? I think you know how I would answer that. You don't really need me to answer that. Maybe, perhaps, I'm not sure. So even with the mom, today, when her son was asking her about what the consequence would be if he decided to break the rule with the Rubik's Cube, she kind of looked at me and I said, it's once and done. You answered the question once and that's it. So she said, I should say asked and answered, and I said yes. So she answered it once and that's it, because what happens is if we continue to give our kids reassurance and we answer their worry questions, as loving and as kind and wonderful as we are, what we're doing is we are inadvertently reinforcing that behavior through negative reinforcement. We're taking the anxiety away, and it is going to cause them to want to keep engaging in the same behavior. So these are all kinds of ways that you can respond to reassurance. These are things after 15 plus years, like a list that I've amassed of all the things that you can say. And I have longer scripts sometimes, as well, but this is a good one. So we have metaphors like watering the worry plant, so we don't want to, we don't want to feed the bully, that kind of thing. So we're going to refuse to what we call co-compulse, which means that I'm going to withdraw engagement at the level of the content. I'm not going to get into this question about whether your hands are clean, or whether the door is locked, or whether there might be a burglar, who's going to break in the house. We've asked and answered that. And what we're going to do is we're going to say one answer is good enough. We're going to maybe label it as a bully thought. Sometimes kids will have them give it a name. We externalize it and personify it. And we'll say, I think that's a worry bug thought. What does Dr. Amy tell us to do about that? We're going to hold the line on sneaky returns, because kids can be very, very good. Anxiety can be very good at getting them to ask. And we're going to move to what we call the meta level. So I'm noticing that you're having a thought, and we're not going to feed the content of it. Another important piece is cultivating parental readiness. So that's an important part that we as therapists play. My job is to really teach the parent to be able to be a partner in the treatment and educate them on everything I know, so that when these things come up at home, that they know what to do. So there's a lot of work that I do with parents in terms of getting them ready to be able to sit with their own tension and anxiety when they're not feeding their anxiety, when they're not feeding their child's anxiety, because it will make you as a parent feel anxious when your child is anxious. And so what you both learn is that anxiety will pass and will not harm your child. You don't have to fix it. You can let your child learn to fix it. You don't need to let anxiety guide the decisions. You can encourage your child to know that they are braver than they realize, than you realize. I've seen kids do amazing things, amazing risks that they've been able to take. And it's always really cool when I get a text from somebody, they'll send me a picture of something that they accomplished, something they did. Like one of my kids, she was really afraid of vomiting. And so we did some exposure work around her putting stickies that just said the word vomit on them, which was really anxiety provoking for her. And she put them on the banister going all the way upstairs, and she sent me a picture of that, which of course is really heartwarming as a therapist to see that and to see her, overcoming that and feeling really confident. To know it will get easier with practice, and together that we can learn to take charge of anxiety. This is a really great video that you can find on YouTube in terms of the specifics of strategies for reducing family accommodation. And then briefly, I'll just talk about PANS and PANDAS. So with PANS and PANDAS, sometimes as an anxiety specialist, we will see clients who have OCD behaviors. They may have restricted eating, they may have tics, anxiety, they may have hyperactivity, depression, they may experience behavioral regression, irritability, bedwetting, changes in handwriting, and sleep disturbances. That may be as a result of an environmental a bacteria or virus. And the little piece I want to say about that is historically, it has been seen as something that had a rapid or sudden onset. But not always. That's the piece that I really want to throw in there. So when you do look at some of the websites on PANS and PANDAS, there's still a lot of emphasis on the sudden onset, which is something that we can definitely see. However, sometimes that's not always the presentation. Sometimes it can be a more insidious onset. And that's a little bit on PANS. I also included some websites that you can go to if you'd like to get a little bit more information. Those are two excellent websites on PANS and PANDAS. Good. Great. Thank you. Thanks.